My name is Selçuk Peker. I'm a professor of neurosurgery. My main interests are radiosurgery, gamma knife radiosurgery, and functional neurosurgery. Today I would like to say you something about gamma knife radiosurgery, the indications, results, and what we do in our hospital regarding gamma knife radiosurgery. Gamma knife radiosurgery, when we talk about gamma knife radiosurgery, we have to say something about radiosurgery at the first. Radiosurgery means to irradiate a small target with single fraction high dose radiation. The term was firstly said by Lexell in 1951. And he used radiosurgery for functional neurosurgery and trigeminal neuralgia treatment. Today, there are almost 300 centers in the world, gamma knife centers in the world, and more than 500,000 patients have been treated with gamma knife radiosurgery since 1968. We use gamma rays to treat the patients, and the sources of gamma ray is cobalt-60 in this technique. We are using gamma knife radiosurgery in Turkey since 1997, and we were 72nd gamma knife unit in the world in that time, and we have treated more than 5,000 patients since then. The effect of radiation in the tissue, mostly we can say that DNA damage and lipid peroxidation. We use these effects of radiation on the tissue. With radiosurgery, you can give the radiation to a small amount of tissue in the brain with high precision. For example, here you can see a residual pituitary adenoma. We gave 18 gray to the periphery of the pituitary adenoma here, but you see the optic nerves and the chiasm is here. The optic nerves and chiasm receives very small doses, but the distance between the tumor and the chiasm is very few, for example 3 or 4 millimeters, but in these 3 or 4 millimeters the doses, the rate of the doses goes to the optic nerves are very low. This is the cross-section of the gamma knife device. You see here, this is the bed which the patient lays down here. This is the helmet, and the cobalt-60 sources are here. When the bed goes in, when the patient's head docks to this area, the cobalt-60 sources gives gamma ray to the brain, into the brain. We can use gamma knife radiosurgery only for intracranial diseases. How we do gamma knife radiosurgery? Of course, this is an stereotactic procedure, so we have to apply a stereotactic frame on the patient's head. We use it with local anesthesia. Then we take MR imaging. We do gamma knife planning in the computer. Then we do the treatment. What are the indications for gamma knife radiosurgery? We can divide the indications like this. The first one is cerebrovascular problems, mostly arteriovenous malformation and sometimes cavernomas. As a benign tumor, we can use gamma knife radiosurgery for vestibular schwannoma, hemangioblastoma, meningioma, trigeminal schwannoma, sometimes craniopharyngioma. The malignant tumors are mostly metastasis, but we can use it sometimes for glial tumors, glioblastoma or astrocytoma. We can use gamma knife radiosurgery for tremor or trigeminal neuralgia in a few patients with epilepsy, or sometimes for chronic pain. The aim of gamma knife radiosurgery in AVM is total occlusion. For the tumor is stop the growth of the tumor. Our aim is to stop the growth of the tumor. Sometimes patients ask us that if my tumor will disappear after gamma knife radiosurgery. No, our aim is only to stop the growth, but in most of the patients you can see the shrinkage of the tumor, or in metastasis, or sometimes in glial tumors you can see the disappearance of the tumor. Also, the aim is no pain in trigeminal neuralgia and no tremor in tremor patients. For AVM, the size of the AVM, the localization of the AVM, marginal doses you gave, and previous embolization is very important on the success rate. The success rate means the obliteration of the AVM, total obliteration of the AVM in 2 years is between 50 to 90%. If the AVM is very small, you could give high radiation doses. Of course, the success rate very high. But for example, if an AVM, a patient has an AVM and it is in the deep structures, for example in thalamus or in basal ganglia, and if it is large, so you could give only small radiation doses, so the success rate is low. But after gamma knife radiosurgery, you have to wait at least 2 years to see the obliteration. So it's very important for informing the patients. The success rate are, you can see some literature here, between 80%, 92% success rate can be seen in the literature. The morbidity, the complication after radiosurgery is low, maybe 1%, 3%. When you compare it with microsurgery, you can see high complication. When you compare it with radiosurgery, you can see high complication in microsurgery. Of course, some patients needs microsurgery. You cannot do gamma knife radiosurgery for some patients. Mostly the patients who has an AVM demonstrated a bleeding, and the surgery is easy for this AVM. If it is easy for this AVM, the first line treatment should be surgery. But if you think otherwise, the gamma knife radiosurgery can be used for these patients. Here's some examples of AVM. Here you see the AVM of the patient, and after 2 years there is no AVM here. And in this patient there is a small thalamic AVM here, and after 3 years there is no AVM. See here and here, no AVM. This is a large AVM with epilepsy. After 2 years there is no AVM and no epilepsy in this female patient. Another patient with small tiny AVM in the thalamus and demonstrated a bleeding here. You see a small AVM here, and after 2 years there is no AVM. This is pre-treatment and this is post-treatment. There is no AVM in this patient. Another small AVM in a very critical area. You see here the AVM tissue, but after 1 year there is no AVM here. This patient is lucky because his AVM disappeared after 1 year. Another patient with AVM you see here. In the MR you see the AVM nidus is here. In some patients, almost 1/3 of the patients, you may see some T2 changes after gamma knife radiosurgery. This is not a radiation necrosis. This is only a edema around the nidus. It disappears after some months. And in this patient, for example, you see AVM nidus is here, and you see AVM nidus and the T2 changes. Then there is no T2 changes and there is no AVM. So when you look at his angiography, this was his AVM here, and after the treatment there is no AVM here. When we talk about cavernomas, of course the first line treatment in cavernomas is surgery. We recommend surgery for this patient. But when the patient's cavernoma is deep in the supratentorial area, or if the patient has brainstem cavernoma, there is a chance to do gamma knife radiosurgery. These patients can be treated with gamma knife radiosurgery. Of course, the aim is decrease the rate of bleeding in these patients. There are some articles in the literature demonstrates that the risk of bleeding decreased in these patients after gamma knife radiosurgery. Also, our experience says same thing. We saw it, so we use gamma knife radiosurgery for cavernomas. Mostly these patients are cavernoma in the basal ganglia, thalamus, or in the brainstem. For example, here there is a cavernoma demonstrating a bleeding here. After 1 year, almost 1 year, you see the hematoma is resorbed by the brain, and the cavernoma is smaller here. And another patient with cavernoma here, when the day of the gamma knife here, and after almost 3 years, you see it's smaller, and there is no new bleeding in this patient. When we come to the benign tumors, the mostly we do gamma knife radiosurgery for meningiomas. Meningiomas are good target for gamma knife radiosurgery because mostly they don't invade the brain and the borders can be easily seen in MR, and most of the meningiomas are vascular tumors, so they are good candidate for gamma knife radiosurgery. And most of the meningiomas which we do gamma knife radiosurgery are skull-based meningiomas and venous sinus invading meningiomas. When you look at the gamma knife series, the tumor growth control rate, it means that stop the growth of the tumor, the rate is very high. You see more than 95%, 98% of the tumors stop the growing in these patients. There are some examples of our patients. From our patients, you see here a tumor after 2 surgeries, and after gamma knife radiosurgery, you see a little bit shrinkage of the tumor in this patient. Another patient with superior sagittal sinus infiltrating meningioma, she didn't operate it, she has no operation, and after 3 years, the tumor is necrotic and a little bit smaller. Here another patient, he had 1 surgery, there is a residual cavernous sinus meningioma. After 8 months, a little bit smaller in this patient. But our aim is not grow. If the tumor doesn't grow, it's good for us. There is a small cavernous sinus infiltrating meningioma here, and after 15 months, the tumor is smaller. Another patient with cavernous sinus infiltrating meningioma, cellular supracellular meningioma, he had 1 surgery, and after almost 2 years, the tumor is smaller here. Another patient with parasagittal meningioma, she had epileptic attacks. We operated her, and after the surgery, immediately after the surgery, you can see some residual tumor here. But we didn't treat this patient with gamma knife radiosurgery. We decided to wait and see what will happen, and so we see that the tumor is growing here. So we did gamma knife radiosurgery for this tumor, and after gamma knife radiosurgery, you see the shrinkage of the tumor. This patient has almost same tumor, parasagittal meningioma. We operated her, then we saw this residual tumor here. We didn't wait in this patient and give a gamma knife radiosurgery, and the tumor is smaller here. So our recommendation is not to wait to see growth of the tumor after meningioma surgery if there is a residual tumor. Do gamma knife radiosurgery, for example, after 2 or 3 months. Don't wait. Another patient with falcotentorial meningioma, after gamma knife radiosurgery, almost no meningioma here. Another benign tumor which we can treat with gamma knife radiosurgery is pituitary adenomas. Which adenomas we can treat with gamma knife radiosurgery? Recurrent adenomas after surgery, or residual adenomas, or the tumors which are infiltrating the cavernous sinus. Of course, in prolactinoma, the first-line treatment is medical therapy, or in Cushing's disease or acromegaly, the first-line treatment is surgery. But in some patients, we need gamma knife radiosurgery, so we can do gamma knife radiosurgery in these pituitary adenomas. With gamma knife radiosurgery, the tumor growth control rate is very high. 95 to 99% of the patients, you can stop the growth of the tumor. The hormonal cure rate depends. Prolactin is low, almost 30 to 40%. In the cases you can see cure of the hormonal pathology. In growth hormone adenomas, you can see in 50 to 70% of the patients the cure of the hormonal pathology, and ACTH in Cushing's disease, the success rate is around 70 to 90%. The complication rate is very low with gamma knife radiosurgery in pituitary adenomas, so mostly we don't recommend radiotherapy for these patients. We use radiosurgery in these patients. Some examples from our series. This is a non-active adenoma who had 1 transfemoral surgery. This is residual tumor here, and the necrosis, the total necrosis of the tumor. There is no tumor here. Another patient with growth hormone adenoma, acromegaly. You see the tumor here. After 1 year, you see the shrinkage of the tumor here. This is very important. After gamma knife radiosurgery, to see some hormonal changes, you have to wait at least 1 year.